I'd like to thank the organizers for inviting me to talk on behalf of my collaborators. So this is the baseline data from our INCHA study. Our INCHA stands for Interactive Transition Support for Adolescents with HIV, comparing virtual and in-person interventions. And the co-investigators are listed there. Just so for some background about how this study was designed, this is a bit dated data now, but it showed that the cascade of care for adolescents in pre-2020s was quite low, estimating that in South Africa about 10% of adolescents were virally suppressed. Luckily, that has improved slightly over time, but showing the need for improving viral suppression among adolescents. We were able to show that in-person adolescent-friendly services improves retention in care and viral suppression compared to standard of care among adolescents. And then building on that, we developed a mHealth intervention based on a lot of the discussion that was in the previous session today. It used closed WhatsApp group chats to improve peer support and improve communication between adolescents and their peers, their caregivers, and their healthcare providers, and addressing many of the concepts that were also discussed earlier, including mental health and peer support. We piloted this intervention and showed very high acceptability and feasibility among the adolescents in the intervention group, and showed a 10% increase in retention and care of those in the intervention group compared to standard of care. In addition, we separately evaluated what differentiated care looks like, or how we could possibly use an intervention to design a differentiated care study. So we developed and validated a transition readiness assessment that can identify adolescents as high, low, and intermediate risk. And this was validated to viral suppression 1 year after transition to adult care. We then took that intervention and turned it into an app so it could be easily used, and adolescents could be quickly and easily screened and put into those categories. Based on that background data, we designed a study called INCHA VIP, which is a stepped wedge cluster randomized clinical trial to determine the efficacy and implementation factors associated with in-person versus mHealth delivered adolescent-friendly services compared to standard of care among adolescents with low or intermediate transition readiness as determined by the HARTS Transition Readiness Assessment. We randomized 16 clinics, 8 in an urban area and 8 in rural areas, all in KwaZulu-Natal, South Africa, to receive either immediate intervention or delayed intervention, and to receive either in-person intervention or the digital intervention. Our inclusion criteria, we used adolescents aged 15 to 19 years at enrollment, all with perinatally acquired HIV. They were all on treatment for at least 6 months and aware of their HIV status, and they scored either low or intermediate on transition readiness assessment. Those adolescents scoring high got put into an observational cohort. So all of this, as I said, took place in KwaZulu-Natal. There were 8 urban, 8 rural sites. Just zooming in, this is the distribution of our rural sites in northern KwaZulu-Natal, and this is the distribution of our urban sites in central KwaZulu-Natal around the city of Durban. We have 10 modules, which are what we call our discussion topics, and these were designed all by using user-centered design with adolescents to talk about concepts that they'd like to talk about. The intervention is the same in both the in-person and virtual groups. In the in-person group, it is delivered in person with research assistants using a printed flipster as to prompt the questions. Whereas the virtual one, as I mentioned, takes place all on WhatsApp and is facilitated by a research assistant with a script who then is able to copy and paste that script into the WhatsApp chat and also interact with the adolescents as they chat. This is the overall design of the study. As I said, it's a stepped wedge cluster randomized trial. So 4 clinics get either immediate virtual group or get put into the delayed group, and 4 get immediate in-person group, and another 4 get a delayed. And then after 9 months, those in the delayed will then get looped into their assigned group, either virtual or monthly, and be evaluated at 18 months. And then to look at long-term sustainability, we're following them up 24 months later. The data I'll be discussing are from here, before the intervention. So this is the baseline data for this cohort. So we screened 858 individuals to get 557 currently enrolled with a high degree of acceptability. Only 55 people declined to participate. And then we had our 3 groups. So those were allocated to immediate intervention, and that was again split into the mHealth and in-person. The delayed intervention also split into mHealth and intervention, and those scoring high on transition readiness, as I mentioned, got enrolled into an observational cohort. Our baseline findings, and this is from all 3 groups, 557, were pretty evenly split between younger adolescents and older adolescents. Slightly more than half were female, and slightly more than half were in the urban area compared to rural, which we expected given the more dense population in that area. And baseline findings, a lot of the population had quite high depression rates, with 11.5 reporting depression. Alcohol and substance use, as you can see, were quite high in this group. Low self-esteem, about 15% reported low self-esteem. And what we had estimated between 10 and 20% would have high transition readiness, and it was at 9.5%. The comparison between early and delayed were fairly well matched among all of the baseline characteristics. Viral suppression amongst the group was also fairly well balanced in the 83 to 84%, no matter how you looked at it, early versus delayed, males versus females, younger adolescents versus older adolescents, all in the sort of 83 to 84% viral suppression rates. And then factors associated with viral suppression, marijuana use was associated with lower viral suppression, and symptoms of depression was also associated with lower viral suppression, and these were adjusted for age, sex, grade in school, geographic location, alcohol, drug use, depression, and self-esteem. Then factors associated with transition readiness, older adolescents was associated with higher transition readiness. Adolescents living in urban area were also associated with higher transition readiness, and adolescents who had used alcohol in the last 30 days was associated with a lower transition readiness. And transition readiness was defined by the HEARTS questionnaire, adjusting for the same factors in the previous analysis. Stigma was quite high in this group. This is the HIV stigma scale. As you can see, almost 80% of adolescents in this group feel some form of stigma, and many of them feeling all of them. And so this was expected to finish the first step in the stepped cluster randomized trial in September 2025. However, as we're well aware of the shenanigans at the NIH, and funding for this study, the year end was in June of this year, and so we've had to stop enrollment and stop the study early. And so step 1, we accelerated to the end of June 2025, which was just a few weeks ago. And so what the step 2 and long-term analysis right now is unclear what's going to happen. Obviously, recently there has been some developments where foreign subawards may possibly be funded, and also the ban on South Africa also may have been lifted, but funds are not flowing, and this study it was ongoing, and so there will obviously be impacts to the participants in this study. So I'd just like to thank all the participants in the study, collaborators, co-investigators, and the funders for this study. So thanks a lot.